give some uh, short lecture about the management of acute on chronic liver failure. And furthermore, we will do the effect of intravenous glycyrrhizin. As we all know, the term of acute on chronic liver failure, starting in 1995, with two insults, then the first definition is two insults to liver are operating simultaneously, chronic and acute. But lastly, in 2019, in the Basel SLF Working Party, the last definition is well characterized acute insult, ongoing chronic liver disease, and homogeneous population. So now this is the last definition. As we all know, acute on chronic liver failure is an acute hepatic insult manifesting as jaundice, serum bilirubin more than 5 mg/cent, and coagulopathy with ENR more than 1.5, and complicated within 4 weeks by clinician ascites and or encephalopathy in a patient with previously diagnosed or undiagnosed chronic liver disease or cirrhosis, and is associated with a high 20-day mortality. So as you can see here, in the SLF, you can hear here, quite different. You have to be careful because chronic injury, like chronic liver disease, cirrhosis, asymptomatic, compensated, no pre-compensated. And the acute insult is, you can hear here, the ethanol, hepatitis B virus reactivation, viral hepatitis, autoimmune hepatitis, drug-induced liver injury, Wilson disease, and unknown. So, finally, patient will develop liver failure with jaundice, coagulopathy, and ascites or hepatoencephalopathy. Even sometimes the condition can be reversible. So, once again, LCLF should be different from acute decompensation. You can see here, this is the hepatic non-hepatitis, always present here, and here the SLF. So quite different between the SLF and the acute decompensation. So you can see here, for the decompensation, usually slowly progressive like this, different with the SLF. SLF, you can see here, they can drop here, but if we can treat this patient, it's possible that the condition can be go back to spontaneous recovery. Or if we fail to treat the patient also will die. So this is, I think, the very important thing, the concept of the SLF. So on this time, I will focus because we know that there's a lot of specific therapy for our patient with SLF. But on this today, I would like just to focus on the HBV nuclear analog because in our country we have also a lot of patients with reactivation of the acute liver failure because of the HBV. As we all know, the role I will continue with the role of glycyrrhizin in SLF, especially for patients with acute chronic kidney failure due to hepatitis B. Now, as we all know, glycerin is a natural compound, possessing anti-inflammatory and antioxidant property and having a brain-stabilizing effect. Derived from glycerin glabrulose, its alkylation of glycyrrhizin is called stronger neomelphagon C, SMC. Intravenous SMC can lower serum level of transaminase. So this is, I think, the recent data from 2019 regarding the dramatic effect of intravenous glycyrrhizin on acute on chronic hepatic failure and chronic hepatitis B without liver cirrhosis. This is a prospective case series following the efficacy of glycyrrhizin plus entecavir on SLF in chronic hepatitis B patient. Every patient received oral entecavir and SFMC 100 cc, which contain glycerin 200 milligram daily for 5 days. Mean ALT and total bilirubin level were more than 2,000 plus minus and 7.22 for the bilirubin. So you can see here that you can see most of the patients have higher, the ALT are higher than 2,000, you can see here. But on day 3, you can see the drop very fast, even the drop of the ALT. And also you can see here also the result is very good. I mean very rapid. So you can see here the data, all the patients who received the glycyrrhizin, you can see combined with entecavir, you can see all the SGPT drop very rapid, maybe within few days, Only maybe 1 or 2 patients who firstly increased first, but in general, more of the all the patients decrease the bilirubin level. So, as I just mentioned that, I think like in Taiwan, also I think maybe in Indonesia, we have a lot of patients with HBV reactivation. That means that patient with already in very good control, but suddenly increase the SGPT and JOT like this. You did patient. Sometimes the patient, because of maybe induced for something, so that the SGPT went very high. So this is another study, glycerin plus tenofovir in acute exacerbation of chronic hepatitis B. This is the 60 patients, Group A, tenofovir plus glycyrrhizin, and Group B, tenofovir monotherapy. And they follow up here, follow up for 24 in treatment, day 1, day 3, 5, 8, 15, and the primary study objective is evaluate and compare the reduction of serum level of IST and ILT. First, to improve the MELD score between 2 groups. And you can see here, those patients with the tenofovir plus glycyrrhizin have better results. You can see here, the compared to the only glycyrrhizin. Yeah. And also here, you can see on the right, the ALT also will decrease. Yeah. That's why I think we can see that the action of the glycyrrhizin quite good, combination with the tenofovir in this guy. So I think from this study, we saw the serum IFL level significantly lower from baseline in the group A patient compared with the group B patient, especially with 1 week therapy. The decline rate of serum ALT level were significantly higher in the group A patient than those in the group B patient until day 15. So although I think in this group, you can see here the patient with the combination with tenofovir and glycyrrhizin have with a better result compared to the only with the tenofovir. So I think the mean of MELD score significantly decreased from baseline since week 1 to in the group A patient, whereas there was no changes relative to baseline in group B patient at week 1 and 2. Subject with MELD score more than 20 at screening, MELD score still decreased significantly from baseline since week 1 in the group A patient. No changes from baseline in MELD score until week 12 in group patient. So we can see here also the safety profile of this medicine, the glycyrrhizin. Even there's some side effect, but I think so far the result is quite good. The expected side effect of intravenous glycyrrhizin treatment usually pseudo-aldosteronism with hypokalemia, sodium retention, and elevated blood pressure. There were no significant difference in hypertension and ascites or leg edema between these two groups. So, Judge, colleague, and chairman, in conclusion, definition of acute on chronic liver failure has been established by the APASL as a working party to emphasize early identification of acute hepatic insult and provide window period for effective treatment. The management of acute on chronic liver failure has been developing using algorithmic approach. In ASL patients with chronic Hep B, antiviral treatment of combined with glycine is safe and beneficial for sale. Probably glimepiride treatment has shown effective reduction in ALT and bilirubin level. Thank you for your attention.
Thank you, Professor Lesmana, for a clear presentation. The next speaker is Professor Jia Hong Kao with the topic reversibility of hepatic fibrosis in chronic hepatitis. Professor Jia Hong Kao was the president of Taiwan Association for Study of Liver and also the steering council of APASL. Professor Jia Hong Kao is well known as the researcher of hepatitis B. He has more than 700 publications, and Professor Jia Hong Kao is recently the director of Division of Hepatology, Gastroenterology, National Taiwan University Hospital. Please, Prof. Gao.
Thank you very much for your kind introduction. First of all, I would like to thank the organizer for inviting me to this dinner symposium at Apostle 2020 in Bali. It's really a pleasure to be here again. So my task today, after Professor Lesmana's talk, is about the reversibility of hepatic fibrosis in patients with chronic viral hepatitis. So my presentation will include the disease burden of chronic viral hepatitis worldwide, and the fibrosis progression in chronic viral hepatitis, and how to assess hepatic liver fibrosis, and the strategies to reverse liver fibrosis, and most important, the role of a stronger neoaminophagan C in the reversal of liver fibrosis. And lastly, the conclusions. So as you know, the chronic viral hepatitis remain a major global health problem for us, and it is estimated we may still have 257 million HBV patients and 71 million SCV patients across the world. And therefore, the total number is 328 million, according to the Global Hepatitis Report. And in our region, the Western Pacific regions, the number is around 129 million. So among these patients with chronic viral hepatitis, 115 million are affected by HBV, and the remaining 14 million are affected by hepatitis C. Therefore, the chronic viral hepatitis is also associated with a significant health burden as well as mortality. So according to the estimate of WHO in 2015, so in the Western Pacific regions, there are more than 440,000 people die of liver-related disease or chronic viral hepatitis. And among them, more than 50% are liver cirrhosis related, and maybe 40% are liver cancer related. Therefore, the disease burden is indeed very huge. And the previous survey also showed that the most liver cancer in our region is, of course, due to HBV and SCV, but proportion-wise may be different. So except Japan, the hepatitis B viral infection is the major etiology of liver cancer in Asian Pacific countries. In Japan, SCV is much more predominant than HBV as the etiology of liver cancer. So then we'll talk about the fibrosis progression in chronic viral hepatitis. So because we know that the chronic viral hepatitis is a progressive liver disease, so it will lead to liver cell damage through fibrosis progression to cirrhosis, liver cancer, and even the mortality, as we see from this cartoon, and also the histological pictures. So it is important for us, the practicing physician, to treat and monitor patients of chronic viral hepatitis in order to prevent or delay disease progression in them. So this cartoon shows the mechanisms involved in hepatic fibrosis development. So any kind of injury to liver cells, so including the oxidative stress, the lipopolysaccharide, and also the paracrine stimuli, will activate the quiescent hepatic stellate cells into the activated myofibroblast. And it will produce some cytokine to stimulate liver cell preparations, which may cause liver cancer development. In addition, the myofibroblast itself will produce the extracellular matrix, the so-called fibrogenesis, that will cause fibrosis progression and then the liver cancers. So if we can inactivate the myofibroblast through we call the resolution, and it can revert to a quiescent hepatic stellate cell again, or we just cause its apoptosis, then we may solve the problem of fibrogenesis and also the risk of liver cancer development in our clinical practice. So how to assess liver fibrosis in our daily clinical practice? So I think the gold standard remains unchanged over the past several decades. That is the liver biopsy. So it's an invasive assessment tool. So we can assess the fibrosis in its histopathological environment. We also have many semi-quantitative scoring systems with high inter-observer agreement. And we can accurate a quantitative evaluation of collagen proportion area by using the morphometry. And we can have insight in dynamic of fibrosis by the immunohistochemical markers. So it can be applicable to any type of chronic liver disease. However, it still has disadvantages. For example, the sampling error, the cost, the limited access, and a small proportion of mortality and even morbidity and even mortality. So this table shows the different staging systems of hepatic fibrosis. We are quite familiar with the Metavir system, Nodal system, and also the Ishak staging system. So for both Metavir and Nodal system, there are 5 stages from 0 to 4. And for Ishak system, from 0 to 6. So have 7 stages. In addition to the invasive assessment, we also have non-invasive serum markers as a tool to assess liver fibrosis. So in this table, I list some. For example, the APRI, the FIB4, the fibro test, HEPA score, ELF panel, and some for the NAFLD disease, I use the NAFLD fibrosis score. So in this non-invasive system, they use some clinical variables and using the formula to have an index. And these serum markers has been widely validated in HCV infection and also in NAFLD. We also have some non-invasive imaging tools, such as transient elastography or fibroscan, and MR elastography. Compared to liver biopsy or serum markers, these imaging assessment tools, they are also non-invasive and most validated for the fibroscan, so it is quite easy to use, and it is also accurate for the detection of liver cirrhosis. And for MR elastography, it has a higher accuracy for detecting cirrhosis than fibroscan. But the cons of transient elastography and MR elastography is they still have some false positive value because of inflammation or liver congestion. And the liver stiffness may change over time. And for fibroscan, for some patients, there are technical difficulty. For example, the obesity. Then I will share with you the strategies to reverse liver fibrosis. So as I just mentioned, so any kind of insult will damage a liver cell and cause necrotic inflammation, and then fibrogenesis, fibrosis progression, and end-stage liver disease. That is liver cirrhosis that will lead to liver failure portal hypertension, and even hepatocellular carcinoma. So we would like to have the regression of cirrhosis to fibrosis, and then the resolution of fibrosis to normal liver. And our strategy is to remove underlying etiologies and using anti-inflammatory, anti-fibrotic, or fibrolytic agents for this particular purpose. So in the literature, there are emerging therapeutic agents for liver fibrosis. The first one, of course, is to remove the primary disease etiology, and especially for viral hepatitis, and we can have some intensive lifestyle intervention. That's for NAFLD or NASH. So this is an example for the regression of fibrosis with different anti-HBV drugs. So from lamivudine to entecavir and tenofovir. So this is an example of a long-term entecavir therapy can reverse liver fibrosis or even liver cirrhosis, and also the histological activity. So in the the left-hand panel, you can see the improvement of a nodal necroinflammatory score from baseline to week 48 and the long term. It's almost more than 5 years. And also the improvement of the fibrosis score from baseline to long term. And the right-hand panel, you can see the liver biopsy samples stained with a Marston trichrome stain to show a reduction in fibrosis. That is the blue area after long-term entecavir treatment. So in a given 60-year-old ENG-negative Caucasian male. And the other agents that can be used for liver fibrosis is hepatoprotective agents and anti-inflammatory and antioxidant therapies. So this busy table shows some anti-fibrotic drugs under development for the treatment of liver fibrosis. But I would like to draw your attention to these two agents. The first one is S-adenosine methionine, and then the shiocyclotol. So they are both antioxidants and has been shown to be effective in alcohol-induced fibrosis or some case report in chronic hepatitis C. So antioxidant is useful for the treatment of liver fibrosis. So this is the most important part of my presentations. That's the role of a stronger neominophagan C in the reversal of liver fibrosis. So the SMMC, the major active compound is the glycyrrhizine, and the details has been introduced by Professor Les Mena. The mechanisms of SMMC contains, it can decrease the cell membrane permeability, interfere with some complement pathways, inhibition of phospholipase A2, and also the scavengers of free radicals. So there is also antioxidant and anti-inflammatory effect. So this cartoon shows that the glycyrrhizine can decrease the AST and ALT levels in patients with chronic hepatitis. So it can decrease the phospholipase A2 activity and then stabilize the membrane permeability and then to have the anti-inflammatory activities. And the use of SMMC has been confirmed in various liver disease. For example, the drug-induced liver disease, the subacute or fulminant hepatitis, as demonstrated by Professor Les Mena in his talk. And also chronic type C patients fail the prior interferon treatment. the patient with autoimmune hepatitis, and those with non-alcoholic steatohepatitis. So in the following slides, I will introduce you a study conducted in Europe. It is a randomized control study with the title of glycyrrhizin in chronic type C patient who failed previous interferon alpha-based therapy, the biochemical and histological effects after 52 weeks of treatment. So the paper was reported in 2012, so a few years ago, by Professor Michael Manns. So this slide shows the flow chart of this randomized control study. So in the run-in phase, more than 600 chronic type C patients who failed previous interferon treatment were enrolled. And among them, 379 received a liver biopsy and then randomized into 3 treatment arms. The first arm, the patient received 5 times of SMMC per week, and the second arm, 3 times SMMC and 2 times of placebo every week for 12 weeks. And the third arm is the placebo group. So there is a double-blind phase for 12 weeks. And all these patients were randomized into the next open phase. So half of them receive 5 times of SAMC per week, and the other receive 3 times of SAMC per week. This for 40 weeks. So at the end of week 52, all of them received the second liver biopsy. So this is the flow chart of the serial change of AST and the ALT change. So this shows the ALT. So during the double blind phase, you can see the rapid decline of ALT level in those who receive SMMC. And there's still not many reductions in those who receive placebo. And further, in the open phase, all the patients receive SMMC either 3 times or 5 times a week, and all of them have a very stable ALT levels. And regarding the necroinflammatory score of the liver biopsy, because this patient have paired liver biopsy, we can have a comparison. There's the end of treatment compared to the baseline. So the total patients who receive SMMC, you can see there's 45% of them have histological improvement in terms of necroinflammation, and 17% remain unchanged. But about 38% still have a histological deterioration. As to the fibrosis score, you can see in the total number of patients, 1/3 had histological fibrosis improvement, 1/3 had a stable disease, and 1/3 had the histological down here. So from this data, I would like to make the following conclusions. So I think the hepatic fibrosis is a consequence of an ongoing liver injury, resulting in activation of hepatic stellate cells, and then increase the deposition of extracellular matrix, that is so-called fibrogenesis. And even at the advanced fibrosis stage, the liver fibrosis remains reversible, according to my previous data. And the main mechanisms leading to the reversal of liver fibrosis are the removal of underlying insults, the deactivation or elimination of hepatic stellate cells, and the switch in the inflammatory environment, and the degradation of extracellular matrix. While nowadays, we still do not have anti-fibrotic compounds approved for clinical use. But there are several reports showing that the drugs like a stronger neominophagan C may be considered to reverse hepatic fibrosis in different kinds of chronic liver diseases. With this, thank you for your attention.
Thank you, Professor Jia Hong Kong, for excellent presentation. Now we proceed to discussion. I invite Professor Laurentius Lesmana and Professor Jia Hong Kong to the stage. Is there any question? Yeah, Dr. Sinta, please.
Thank you. My question to Professor Lesmana. Prof, does this agent can be used for acute increase of transaminase enzyme? Because as we see, most of the trial has been done on the background of chronic hepatitis. So as we know, now a lot of the practitioners use this agent for the acute increase of the enzyme transaminase. For instance, when there is a increase of liver enzyme in the patient undergone, for example, chemotherapy. So can we use this agent for like an acute condition like that? Thank you.
Please,
Yeah.
Professor.
Thank you for the question. I think for the result with the vacancy, we can already show that for the two study with the SLF and combined with antiviral, and if we combine with SMMC, it seems that the GPT very rapid decrease. But if you ask me about the role of FFNC for patients with cancer, yeah? You ask for cancer? Oh, drug-induced liver injury. Yeah, in general, if we are, sometimes we are invited, especially patients with in ICU, maybe there's a lot of antibiotic management. So sometimes, because of the GPT going up, even there's no virus HBV, usually in our experience in the ICU, we can reduce the GPT because sometimes we don't know how can they improve the condition. But so far, like in ICU, if the patient invited us with very high GPT, no virus and so on, sometimes we start with the SMMC. Even not all, but I think quite enough patients could receive the medicine so that the LT can decrease. This is my experience in ICU in Medisra. Thank you.
Thank you. Professor, please, Dr. Abdul.
Thank you, Dr. Richard. My question to Professor Jia Hong Kao. I would like to ask you about we know in the liver fibrosis or liver cirrhosis, the destruction not only in the hepatocyte, but also to the canalicle or the architecture of the liver. But according to the result of the fibrosis, the ISHAQ score is getting better. My question is, how the SMNC rebuild the architecture of the liver? Or the other question is, who rebuilt the architecture of the liver? Thank you.
I think the first question is about how to evaluate the architecture change of the liver during the fibrogenesis. Yeah, indeed, it's quite difficult according to current non-invasive assessment methods, either during the serum markers or using the transient elastography, FibroScan, or the MR elastography, because they only quantify the fibrosis content. So you cannot see the fine change of architectures. So to this point, I think the liver biopsy is still the gold standard to see the architecture improvement. Or you can see maybe the erosion of cirrhotic nodules, the very thickened fibrotic band into the thin fibrotic band. I think maybe at this moment, only the liver biopsy can do the job. So how about, what's your second question? Your second question?
The second question?
Actually, almost the same with the first question. Actually, who actually rebuilt the architecture, the SMNC or the hepatocyte itself? Thank you.
Thank you.
Okay, any more questions? I have a question to Professor Jia Hong Kao. You mentioned based on Professor Michael Mann's study that 5 times SNMC is very useful for the patient with chronic liver disease. So what is your recommendation for us to this type of patient? To give SNMC 5 times a week or 2 times a week? And also, what is your experience in Taiwan? Because it's not easy to give IV drugs every day or 5 days in a week for many years. Thank you.
It's a very practical and is a very practical questions for clinicians. So according to the study conducted by Professor Mans, so in the open phase, they use either 3 times or 5 times a week. And we count all the patients. I think even the 3 times a week still can have a significant reduce the liver fibrosis. So maybe 3 times a week is okay. And the next question is because it's the intravenous use. So not many patients can have this kind of treatment at home. So they still need to go to the hospital or to the local clinics. So in Taiwan, this drug is not reimbursed, but we reserve these drugs for some patients who can afford it, and with a very significant fibrosis. But of course, we need to remove the underlying etiology at the same time. For example, the HBV or HCV, and then to see if the fibrosis stage is very advanced, or even with some evidence of hepatic decompensations, maybe and still have high ALT. Maybe you can use this kind of the SNMC to reduce the necroinflammatory activity, and then over time we can reduce the liver fibrosis. Yeah.
One more question. Most of SNMC studies in Japan were on hepatitis C patient. And now we are in the era of DAA. Most of cases can be cured. So my question is, Now, what is the indication of SNMC for hepatitis C? We know that for the patient with hep C and cirrhosis, there is still a chance of HCC. So can we give SNMC for this kind of patient?
Yeah, it's also a very good question because SNMC is reimbursed in Japan. So the Japanese physician can use these kind of drugs. And there are several international guidelines for HCC patients who receive the DAA. If they are, the baseline fibrosis is above F2, so they are still at increased risk of HCC development. So maybe for patients with advanced liver fibrosis, we can use these kind of drugs trying to reduce the severity of liver fibrosis, and then we can reduce the risk of HCC over time. So that is one of the strategies. But however, we still need some long-term data to confirm whether this kind of regimens is effective or not.
I was asked to you for treating patients with fibrosis. I think maybe we have used for a long time.
Yes.
Is this medicine safe or not? I mean, if we give the patient, for instance, for 1 year, because for SLF can very rapid. So, do you have any maybe experience about the toxicity of SFMC or not?
Yeah, I think if we consider long-term use of a given drugs, so the safety issue is always a concern. I think for the SNMC, there are some report concerning about maybe due to the hypokalemia, something like that. So when we have a long-term use, we need to check the potassium level regularly and trying to adjust the dose or maybe give some potassium the supplement.
Any question, Dr. Julwan? Okay, because both of the speakers have to have their dinner, I think I have to end this session. Please give a big applause for the two speakers. Thank you, Professor Lesmana, and thank you, Professor India Hong Kong.